Hola, buenas noches, ¿cómo están? Bienvenidos a la novena sesión eh, o- ordinaria de la Sociedad Mexicana de Cirugía de Mano y Microcirugía. El día de hoy, como ya les habíamos mencionado, vamos a tener una sesión conjunta junto con la Sociedad Serbia de Cirugía de la Mano. Y bueno, le damos la bienvenida a todos los que están aquí de forma presencial, que van a tomar un vino al final de la sesión, y a todos los que nos acompañan de forma virtual. Em, Recuerden, por respeto a los miembros de la sociedad serbia, parte de la sesión se va a dar en inglés y al final vamos a dar un par de avisos con respecto a los miembros de nuestra sociedad, eh, pues que será en español, espero. Bueno, entonces, sin más preámbulo, vamos a empezar con la primera charla. am, que mm, yo sí, pero ¿cuál es? ¿Listo? Mm, Listo. Mm, Espera, lo vuelvo a abrir, ¿no? Ujú. Ok. No, hay, no, es 4 minutos tarde. Ok. Well, good night, everyone. We welcome the Serbian Society for Hand Surgery, and I would like to give a couple of words about Dr. Professor Marko Bumbasirovic, who was named for the Federation of European Societies for Surgery of the Hand a giant in 2024, and he is the founder of the Serbian Society. And we share with him some of his work in Serbia 2 years ago when he was the president of the CICOT Congress in Belgrade. Another important person in Serbia is Professor Milan Stevanovic, who works now in California, but in Serbia he gave a wonderful lecture about Dr. Vojislav Subotic, who was the founder of Serbian surgery, and he is a professor of Dr. Bumbasirevic and the current members of the Serbian Society for Hand Surgery. And here you can see some of the members of that society. They also have a fellowship with fellows from Africa and Asia. And this is Belgrade, the capital city of Serbia. And they are very far from here. It's 3 a.m. in Serbia, and they speak a very different language. They write in Cyrillic alphabet, so it's very hard for them as well to have this conjoined session with them, and we are grateful. And Dr. Tomislav Pavlich and myself directed a microsurgery free paper session in Madrid this year. So I am very grateful for them to be here in this session. So this is the National Institute of Rehabilitation where we work. And this is an image for our last Congress held in that institute in May earlier this year. So distal radius and ulnar surgical anatomy. We're going to talk very quickly about this. So remembered about the column theory about Rickley and Regazzoni that refers to the radiocarpal joint with the lateral and medial columns, and the DRUJ and the ulnar side of the joint as the ulnar column. It's really important to know the anatomical landmarks that are going to help us during the physical examination, as well as the surgical approaches when treating distal radius fractures. So one of the main landmarks is the Lister's tubercle that is very easy to palpate on the dorsal aspect of the hand, just proximal to the joint surface. And as well, we can palpate the fovea of the ulna, just proximal to the pisiform. It is important to know these landmarks because we can detect associated injuries before the surgery and plan or surgery before, and taking into account if we need to use a scope or anchors or advanced techniques for fixation. So there's a flexor retinaculum on the volar aspect, but most important is the extensor retinaculum. And when we are dealing with a specific fragment fixation or dorsal approaches or the RUJ instability problems, or the fixation of a big ulnar fragment, we need to remember these structures. And if you remember, between the second and the third compartment, we can see the Lister's tubercle, which is the most important landmark, again, during the dorsal approach. But palmarly, which is the most common approach nowadays, we have very strong ligaments, the extrinsic ligaments that comes from the radius and the ulna and attached to the carpal bones. And we can see here the radial extrinsic ligaments, the radius scaphocapitate, the long radial lunate and the short radial lunate are cut in this specimen. And we can see the ulnar ligaments attached to the triquetrum. And dorsally, the most important ligaments are the dorsal-radial carpometacarpal ligament and the radius scaphoid and the radial lunate ligaments. So we can see here on your left side, the extrinsic ligaments are removed, and on the right side, you can appreciate the dorsal intercarpal ligament and the dorsal radiocarpal ligaments, as well as the ulnar collateral or ulnotriquetral dorsal ligament. And very importantly, we may remember that this structure, the TFCC, as well as the ulnar styloid, are always associated to distal radius fractures. And even if we don't need to fix it, we need to do a proper diagnosis and rule out the RUJ instability. Another example is the volar Barton fracture that I'm going to talk about in the following minutes. You can see here how since many, many years, it's been said that this is a 100% surgical injury. And we're going to remember why is that. So as Dr. Gregory Bain told us, the distal radius have the radial and ulnar calcars, which is a volar, the most extreme volar and distal part of the radius that has thickened trabeculae, and the volar cortex is really thick in this area. That's why when we have a distal radius fracture, it's more easy than we have dorsal comminution than volar comminution. And on the sagittal plane, we can see that there's like a shape of a Gothic arc between the middle aspect of the radius and the lateral aspect of the ulna. So this is another important part that bears weight, and we need to take into account when we are doing our surgery. Another important thing is the watershed ridge, which is the most volar distal radius aspect in the volar side. And if you can see here and the upper left, the pronator quadratus doesn't go all the way distal to this area. So when we cut very distal, we can cut the extrinsic ligaments and produce an unstable carpal. So we need to be very careful and do the myotomy just in the transition between the muscle and the tendinous part. Another important thing is that if you can see in this specimen on the below area of the left side, the short radiolunate ligament is distal to this watershed line. And this is very important to take into account when we are doing surgeries. So, as Dr. Bain and colleagues showed us, there are even 8 different concepts about the watershed line, but we need to be aware that the most important thing is to fix the volar lip, the most distal area of the volar lip. And Orbey knew that, and if you can see in the original volar plate, this most medial column and distal part of the plate was more distal, trying to engage this volar lip. And they published this paper in 2002 along with Dr. Diego Fernandez. And this, we know, changed completely the treatment of distal radius fracture, mainly avoiding soft tissue problems associated with dorsal plating and with external fixation as well. But if you can see here, there are several brands available to use, and not many of them can fix this volar lip properly. After the Rickley and Regazzoni concept of the 3 columns, Brink and Rickley in 2016 published this fragment-specific fixation that was published before, but with these CT scans, they showed us that there are 4 corners: the radial corner, the dorsal, the volar, and the ulnar corner. And this was based on, again, Dr. Bain's studies about the osteoligamentous units of the distal radius. And if you can see in the left image, we have bare areas of the distal radius that doesn't have any important ligament insertion that are marked just in black, but we have very important areas marked in red with the insertion of extrinsic ligaments. And if you can see on the right side, the most common patterns, well described before by Meloni and others, are these 3 most common parts: the lateral column and the medial column commonly breaks in 2, one dorsal and one volar. So let's put an example on the short radial lunate ligament. If we put a conventional plate on the volar aspect of the distal radius, we can fix mostly all the fragments, but even in this anatomical picture, there's no description of the short radial lunate ligament, but it is really important. We'll see why. So you see that the short radial lunate ligament originates next to the volar radioulnar ligament. And if we have this injury, we will have a shift proximally and volarly, and we will also have a pronation of the fragment. If you can see here in this axial CT scan, the fragment pronates, and so we need to find the key corner in a sagittal view of a CT scan. We need to see the fragment that is in relation to the lunate, the center of the carpal bones, and this will be named our key corner, and this is a corner that we need to fix first. So put this one as an example. We can see here in purple the key fragment, and the lunate is displaced volarly along with this fragment. So with the fixation, it's enough to correct all the deformity. And this is the classically described as Barton fracture. But this is another important thing that Dr. Bain showed us. As the fragment pronates, you can see here on the upper left, the scaphoid tends to go with this fragment and is not aligned properly on the scaphoid fossa. So all the carpal bones can, the lunate. So all the carpal bones will be translated if we have this very tiny fragment fracture. So we need to take into account that. And if you can see here on the upper right, even the scaphoid can luxate in this with some of these injuries. You can see here, even with very distal plates, if the fragment is really small and is not fixed properly, the carpus can displace. Okay, I'm going to talk very quickly about external fixation. We don't use external fixation a lot, only for trauma with soft tissue extensive injuries, Gustilo type 3A or 3B or 3C open fractures. But there are several places in Mexico that there's still the main surgical treatment. So for those who are obliged to use this, it is important to identify and protect the dorsal sensory branch of the radial nerve, to identify the extensor carpi radialis brevis and longus and the brachioradialis, and make a separation between them, and augment with K-wires or screws or even plates the fixation, because sometimes it has a lot of complications. So the external fixation will go always with a soft tissue protector, and the drill guide and the fixator pin will need to be next to the bones. All the soft tissue needs to be taken on the side. And another important thing is to put it in the center of the bone, the metacarpal or the distal radius, but always in the center to avoid complications or fractures. And as you can see here, we need to develop the interval between the extensor carpi radialis longus and brevis and the extensor digitorium communis to place the radius pins. And just to finish, I'm going to talk about dorsal, surgical approaches. So the most common used nowadays is the modified Henry approach, described by Diego Fernandez in 2002 and Jorge Orbay. And remember that we need to use the flexor carpi radialis and the scaphoid tubercle as landmarks to make the incision, protect the median nerve on the on the medial side, and the radial artery on the lateral side. Okay, when we have this very tiny middle column fracture that I spoke about before, uh, sometimes we need to go medially and just cut ulnar to the median nerve and enter through the flexor tendons. Also, the extended flexor carpi radialis approach, which allows us to move all the distal radius, put graft, see the dorsal aspect of the distal radius, and but I don't like this one too much because we need to dissect a lot, and we can have more complications. And well, obviously, the dorsal approach that was used before this volar plate boom, but it is important to know it because when we are doing a specific fragment fixation, we will have to do it dorsally, and we need to be very careful with the extensor tendons. Okay, just to finish, remember the danger zones for flexor tendons in volar plating of distal radius. It will be 6 millimeters proximal to the watershed line to protect the flexor digitorum profundus of the index and the flexor pollicis longus. Another very useful paper is this one published in 2015, 10 years ago, that the lunate depth can predict the length of the screws that we place in the distal part of the radius plate. And another important thing is to prevent a coronal shift malreduction, just to putting a retractor on the medial aspect of the radius, and with that we can correct the coronal shift. So as conclusion, anatomical knowledge and its surgical application are paramount for good outcomes, and we are looking forward to collaborate more with the Serbian Society for Hand Surgery. Thank you for your attention. Okay, now it's the turn of Dr. Tomislav Palibric, who is going to talk about principle of distal radius fracture treatment. Okay.
Dear ladies and gentlemen, my colleagues, my name is Tomislav Palibrk. I'm orthopedic surgeon from Serbia, Belgrade, and I represent, along with my colleague Slađana Matic, Serbian Society for the Hand Surgery. Serbia's Society for Hand Surgery is a small group of professionals and enthusiasts from Serbia. There are around 15 of us. President is Professor Marko Bombaširević, who is also the founder. Most of our members is from University Clinical Center in Serbia, in Belgrade, the largest medical facility in Serbia, and most of us are orthopedic surgeons. First of all, I would like to say thanks to the host for inviting us to give a lecture at this expert meeting and combined session between Serbian and Mexican hand societies in distal radius. Unfortunately, due to time difference, this lecture is pre-recorded, and I'm sorry that we would not be able to have a discussion on this topic. The topic of my lecture is Principles of Distal Radius Fracture Treatment, non-operative versus operative, and this topic is always controversial. Dear ladies and gentlemen, let's get back in time for a little bit, around 5,000 years ago in ancient Egypt. According to the papyri written in hieroglyphs, there are records from 5,000 years ago, from the time of the ancient Egyptians. They describe the manipulation of a broken arm in order to straighten it and immobilization with a piece of wood that is wrapped in linen cloth and coated with a combination of fat and honey to maintain the position. So basically, on this papyrus we have broken arm, probably distal radius, and the principles of treatment that have not changed much even to this day. Of course, nothing could have happened without Hippocrates. In the Hippocratic Corpus, he described dislocation and subluxation of radiocarpal joint and the treatment. Probably it was a distal radius fracture, and described the both treatment, manual reposition, and bandaging of the injured arm. Probably, in large number of the cases, basically it was the fracture of distal radius. Of course, nothing could have happened without Hippocrates. In the Hippocratic Corpus, he described dislocation and subluxation of radiocarpal joint and the treatment. Probably it was a distal radius fracture, and described the both treatment, manual reposition, and bandaging of the injured arm. Probably, in large number of the cases, basically it was the fracture of distal radius. And now, as you can see on the image, on the slide, nothing has changed from that time till now. Basically, principles are the same. And now, as you can see on the image, on the slide, nothing has changed from that time till now. Basically, principles are the same. And now, in 19th century, Coles described on the fracture of the carpal extremity of the radius, and he described distal radius fracture and said that all recovered without the smallest defect or deformity of the limb. But is that true? We'll never know. In 19th century, later comes the era of inventions. X-rays were discovered by Röntgen and revolutionized orthopedic diagnostics. In the middle of the 19th century, Lister came to us with antisepsis and surgery became a reasonable option. Lamothe performed the first wire fixation of the distal radius fracture. Later comes the era of Later, some other options were tried with traction in combination with plaster and with external fixation, which is very similar to one we're using today. Later, and then comes the era of the technology and prosperity. Kapanji with interfocal fixation with K wires, external fixation as we know it today, and in the 90s plates and screws are introduced. In the last decade comes the popularization and application of locking plates, which we still use today at everyday basis. Today, we have better understanding of radiocarpal anatomy, wrist biomechanics, and bone tissue physiology. We continuously strive to perfect our surgical technique. There are over 30,000 of papers that can currently be found on this topic, not to mention textbooks, congresses, online educations, YouTube. The most modern diagnostics, modern surgical theaters are available to us. And despite all that, this is happening to us. So, what we can do to make sure that the results will be good? Treatment can be non-operative and operative, and what we choose depends on multiple factors: fracture type, stability of fractures, but also geographical distribution, culture, economy, availability of implants, and education of general orthopedic population. Goal of our treatment is good range of motion, painless wrist, strength, stability, aesthetics, of course. Badly fused fractures lead to the disorder in joint kinematics, loss of strength and range of motion, development of early arthritis, load on the ulnar side, and the TFCC. With adequate treatment, we try to achieve intra-articular congress of radiocarpal and distal radial-ulnar joint, to achieve good palmar tilt, radial length, radial inclination. So we strive to comply with the radiographic parameters, although this does not necessarily mean successful treatment and good results. We can achieve all this with non-operative treatment, with reduction in mobilization, one of the most common methods of treatment with cast, splint, functional brace, of course, if we set the right indication. Non-operative treatment is mainly reserved for so-called stable fractures. Stability depends on the force that acted, the initial dislocation, age, bone density, metaphyseal comminution, and condition after the reduction. There is a lot of controversy about elderly patients. You know that we have two groups of patients with distal radius fractures, young ones and old ones with insufficiency fractures. So basically, the old ones are large amount of our clients. In numerous papers, they compared Mayo Ritz score, quality of life, DASH score, range of motion, pain, grip, strength, basically in patients that were treated operative and non-operative, elderly patients, and no difference in functional result after 1 year is found. Operatively treated patients only had better radiography findings. But today, elderly people are more active. They are going on hiking, lifting weights, doing yoga. Age is now just a number, so we have to pay more attention to them. And not all old people are considered for non-operative treatment. We have to individualize the treatment for them also. So, if we decide to treat general patients with distal radius fractures, we must know what is an adequate reduction, can we achieve it, will it stay in the cast, and when to operate the patient. So what is the basic principle of non-operative treatment? We reduce the fracture, we put it in a cast, splint or functional brace. We wait for sometimes about 1 week for swelling to reduce, and if it's reduced and there is more space in the cast, there is a risk for fracture to dislocate. Then we perform X-ray after 1 week, 2 weeks, and if we see the loss of position and displacement even after 6 weeks, we can't non-operatively treat those patients, we have to operate them. There is mostly radial collapse due to osteoporosis, and if we reduce the fracture at the first time and we don't achieve adequate position, maybe we shouldn't try the second time. Basically, great majority of distal radius fractures do not need surgical treatment. Yes, it is fun to do surgery, but it can also be harmful for patients. Ask yourself, would you operate yourself in the same case? And what about the scientific community? There is no consensus. American Association of Orthopedic Surgeons have recommendations with moderate strength due to lack of compelling strong evidence. In green textbook and in British Orthopedic Association, there are considerations of the individual patients and factors, including fracture stability. So literature cannot be applied on individual patients. So what we have to be aware of if we want to treat patients with distal radius fractures. We must be aware of articular surface, distal radial ulnar joint, volar dorsal tilt, radial translation, palmar or dorsal translation, mid-carpal malalignment, and positive ulnar variance. And what are the indications according to the literature? Comminuted intra-articular fractures with dislocation, open fractures, combined fractures of distal radius and wrist, concomitant soft tissue injuries like nerve tendons, dislocation of previously reduced fragments, fracture of both arms, and early mentioned the stability of the fracture, so unstable fractures. And the Anglo-Saxon literature explained it nicely. The term unstable distal radius fracture describes situation in which the distal radius fracture has an intrinsic potential for secondary displacement. There are also Lafontaine criteria: dorsal angulation bigger than 20 degrees, dorsal comminution, intra-articular involvement, associated ulnar fracture, age 60 plus years. If 3 or more of 5 criteria are present, the fracture will lose position in the cast. If we go back to the radiographic parameters, unstable fractures are the fractures with radial inclination less than 15 degrees, volar tilt more than 15 degrees, radial height less than 9 millimeters, radial shortening more than 3 millimeters, dorsal tilt, intra-articular gap. But again, even the radiographic parameters do not guarantee success and a good result. So, if we decide to treat patients operatively, we have different options. Everyone should do the technique that is best for the patient, the one he is familiar with, and the one that is the most suitable for the case. We can use percutaneous fixation, fixation with K-wires, external fixation, hybrid fixation with K-wires also, plates and screws, buttress plates, conventional, LCP, anatomic. It all depends on the conditions in which we work. The latest materials and plates and screws are not available to everyone. Nowadays, we most often use different type of modern LCP, locking compression plates with locking screws, and today there are more and more sophisticated materials, plates and screws for even small fragments of the distal radius, but you're all familiar with that. Arthroscopy of the wrist is a relatively new technique. What is the advantage of arthroscopy? That is, what are the indications for arthroscopy in fractures of the distal radius fractures? Multifragmentary intra-articular fractures with or without comminution, die punch fractures, carpal bone fractures, ligamentary injuries, distal radial ulnar joint lesions, TFCC. Arthroscopy is used for both diagnostic and therapeutic purposes. And why is it important to visualize the wrist arthroscopically? Research has shown that arthroscopy is more accurate than fluoroscopy when we're dealing with intra-articular fractures. So basically, what do we actually want to achieve with operative treatment? We want to achieve direct fragment reduction, early rehabilitation, faster recovery, faster return to everyday activities, achieve the best possible anatomic reduction, adequate stability with minimal tissue traumatization. So, do not neglect distal radius fractures. They are as important as any other fracture. Respect protocols, choose the treatment method that you are most familiar with, and one which is appropriate for given fracture. You have to think about every patient as an individual. And according to research, whatever method you choose, after 1 year, all patients that are treated adequately, operatively or non-operatively, have the same results. And if you follow up the patients adequately, the results will be good. Thank you very much, and warm greetings from Belgrade, Serbia. Good.
Well, good night, everyone. And after that great talk, which summarizes nicely what we do with distal radius fractures, I'm going to talk a little bit about complex distal radius fractures and what would the current treatment protocol would be. So first of all, we have to define what a complex distal radius fracture is. And they all are high energy injuries, although nowadays we might find ourselves with complex distal radius fractures in patients with low bone density and therefore no need for a high energy injury. They all have certainly articular disruption. They might have, or they certainly will have comminution. And we might be able to see ligamentous instability and perhaps even soft tissue injury and neurovascular injury. This last is perhaps one of the most important key factors to determine when we are approaching our patient with a complex distal radius fracture. So our initial evaluation will be always to assess the neurovascular integrity. We might be facing a patient who has a compartment syndrome and which might have even decrease in the blood flow to his or her extremity. And therefore, we might need to take a step back and treat first this soft tissue damage. So in the case of open fractures, an early aggressive debridement with irrigation and reduction are key for a good treatment. We need to aim for coverage of the fracture in the first week after the injury has been sustained. And definitely we need to be able to diagnose correctly the extent of the fracture. And certainly we might need to use computed tomography to have a better image of what the fracture means and how many fragments it has. So once we are done with that initial evaluation and that we know that soft tissue is in good shape to start, we need to go back to the basics, which we have been talked about in the previous talks. The column model anatomy is certainly one of the best guides for us to treat distal radius fractures. And you know, Dr. Farias already told us about these four main parts of the distal radius or the wrist anatomy, which are the radial, the intermediate, the ulnar, and the pedestal columns. In the complex distal radius fractures, we might see that all these parts will be involved in the injury. So, as we were just told, what will be our goals to achieve with our treatment? First of all, a radial inclination of more than 15 degrees, shortening of less than 5 millimeters, a step off, articular step off of less than 2 millimeters, and also in the sigmoid notch, less than 2 millimeters, and with a radial tilt of between minus 15 to plus 20 degrees of flexion. So also we were talked about the fragment patterns by Dr. Farias, and we have these key areas that will require fixation, not necessarily by plating, but by any means possible, so that we can achieve stability in our wrist. So, as we were told before, we have many options to treat our patients, and with Boller locking plates being the workhorse in distal radius fracture fixation, we have also encountered many complications with the use of this type of implants, mainly because we don't respect the natural anatomic landmarks, being the watershed line, the form of the dorsal aspect of the radius, which might lead to protrusion of these pegs or these screws. Also, the possibility of these screws going into the intraarticular aspect of our wrist. And we need to be aware that when we are using boller plates, we need to at least have two distal screws, mainly two subchondral screws that need to be at least 3 millimeters from the subchondral area. And we need to also, when we are assessing our treatment, we need to have correct X-ray views to see if any of these screws is out of place or if the fragments are not well reduced. So this has also been a current form of treatment for comminuted fractures. The use of fragment specific is something not really new, but that has gained some popularity in the last few years. And this is because we have the possibility to treat every fracture with a specific implant that will give it stability. So, as you can see in this slide, there are many different types of implants that will help us maintain these fragments in place. Finally, we have all faced fractures like this one. This one is a patient in our institute who sustained distal radius fracture and a distal ulnar fracture. And whenever we see a case like this, even the most experienced surgeons start thinking, what am I going to do? So anyone could say, well, perhaps a Boller plate, or perhaps an external fixator, or maybe even fractures, fragment specific plates, or even spanning plates, which are also a good option. Finally, as we were just told, all options are good whenever these are suited for our patient and suited for the surgeon who needs to have the experience to use them and obviously to treat the patient. So this was going to be so okay. In complex distal radius fractures, we might need to use external fixation, as we were told before. When there's extensive soft tissue damage, and when we don't have all that is needed to treat the patient in the moment. Along with the external fixation comes also staged open reduction and internal fixation. And we see that the outcomes in doing so might be good in the union rate, but might not be so good according to complications. Mostly in these cases, we might see a 40% complication rate, mainly in post-operative infections. And it has been seen more with the dorsal approach for the fixation of these fractures. So we need to be very careful in the use of this type of treatment in our patients and use it very selectively. Bridge plating or spanning plates are also, as I told you before, a good option treating complex distal radius fractures. And this can be combined with percutaneous pinning, other plates, and they will give us time also for bone to heal and for fragments to align a bit, and even for soft tissues to gain some better chance to survive. So we need to have this in our arsenal. Advanced imaging has been something that is rising currently and is not readily available everywhere. So this image is, I think it's very illustrative of what I'm going to tell you. See, as perhaps everyone in the room and in online has done, when we treat a distal radius fracture with a Bowler plate, we might use this skyline view to see if any of our distal screws is protruding to the dorsal aspect. And sometimes the screw might be protruding, but as the carpal bones superimpose, it might seem that the screw is in place. When we use something like intraoperative 3D fluoroscopy, we might see that these screws are protruding, and that might help us take the decision to change it or to change our reduction or our fixation in the moment. Unfortunately, it's not available everywhere, and this is something that perhaps could be of help. Finally, in all our patients, we need to think about rehabilitation, and as in any other orthopedic treatment, early range of motion when the fracture is stable is of great importance. Also, rehabilitation can help us treat our patients' edema and scar control. Finally, what I want to give you for the treatment of complex distal radius fracture is this brief algorithm in which we need to think first of the soft tissue injuries, restore length, perhaps use a CT or even AI for our patient, for our fracture patterns, fix. And this is very important, and I missed to tell you, but when we're treating complex radius fractures, we need to treat first the intermediate column. After we've done the intermediate column, we need to do the radial column. And finally, if there's instability in the ulnar column, we need to address that. Finally, we can use either implant available as long as we know how to use it. And we need to treat our patient with early rehabilitation for range of motion recovery. Thanks for your attention.
Thank you very much, Dr. Valencia. It was a very nice talk. Thank you so much. And so the last talk we're going to have tonight will be given by Dr. Svetlana. I don't know where's el video, ¿dónde está?
It is a great pleasure for me to participate in this webinar, and I thank our colleague, Dr. Farias, for the idea that colleagues from Mexico and Serbia exchange experience in this way. I'm sorry that due to the time difference, we cannot participate directly in the discussion. My topic is complication after a fracture of the distal radius, and I'm trying to list most of them and somewhat systematize. Complications occur, of course, in both non-operatively and operatively treated fracture, but we couldn't say that numerous complications on non-operative treatment have become the main reason why increasingly frequent indication for the surgery. We can classify them in immediate, early, and late complication. Immediate involve nerve injury, skin damage during manipulation, and compartment syndrome. Early complications are loss of reduction, infection, tendon rupture. Late complications occurring beyond 6 weeks include arthrosis of the joint and the complex regional pain syndrome. Nerve injury are, we say, relatively common, and the incidence in the literature ranged from 0 to 17%. Most often, it is an injury of the median nerve. Compressive neuropathy of the median nerve occur more often, and according to the literature, occur from low energy trauma in 1 to 12%, and in high energy injuries in 30%. Acute carpal tunnel occurs within hours or days after fracture and is caused by hematoma, dislocation of the fragment, immobilization and swelling of soft tissue. It can be prevented by avoiding immobilization in excessive wrist flexion and ulnar deviation in cotyloidal position. In one study, Gelberman measured the pressure inside the carpal tunnel. He found that in a neutral position, the pressure is 17 millimeters, and when we flex the wrist on 20 degrees, it increases to 27, and in flexion on 40 degrees, it rises to 47 millimeters. It is measured in the normal wrist. The measures are much higher in the wrist with hematoma, fracture, and swelling. Acute carpal tunnel syndrome is more common in patients who have more severe and comminuted fracture, and also in those undergoing multiple close reduction attempt, also in polytraumatized patients, high energy trauma, and we find in the cases with radiocarpal dislocation. In contrast, delayed carpal tunnel developed weeks after fracture, which is thought to be due to a change in the carpal tunnel anatomy after healing the fracture. The proposed pathophysiology for these delayed cases include fracture malunion, chronically tenosynovitis, volar and scar formation, and the presence of the hardware. One study found an incidence of the carpal tunnel of 9.2% within 6 months of the fracture. It occurred in 6.3 on those who treated non-operatively, of which about half required surgical decompression. In surgically treated fracture with volar plate, carpal tunnel was found in about 20%, and more than half of the patients required decompression. Also, very interesting data is total of 18.5% people who had a second surgery. Obviously, it is very difficult to compare this because mostly severe fractures and comminuted fracture were treated operatively. But this finding of 18.5 now, because of that we think that we have another question. Perhaps a careful evaluation of the patient during the primary surgery, during the fixation and the volar plate, may be the moment when we may do, maybe, just maybe, a prevention carpal tunnel release. We don't do routinely in our practice, but I just suggest maybe it is some solution to escape second surgery. Carpal tunnel release should be considered if the symptoms are more severe or progressive. Patients who undergo early release have a better long-term outcome. And the indication in acute carpal tunnel is progressive paresthesia and weakness in thumb opposition. Compartment syndrome is a rare complication, but have dramatic consequences. Young male patients are most at risk because they are more likely to have sustained high-energy injury, and patients on anticoagulation therapy have increased risk of developing compartment syndrome due to a higher risk of internal bleeding. This is a surgical emergency, required immediate diagnosis and treatment. Signs and symptoms are severe pain that is out of proportion to the injury. Pain is not relieved by medication, and of course gross swelling, weakness and numbness. Although not strictly complications, missed associate injuries are often overlooked, and because of that they become a complication. Associated condition as injury of the distal radioulnar joint, radial styloid fracture with ligament injuries, indicates higher energy mechanism. Soft tissue injuries, such as a lesion of trifibrocartilaginous complex, scapholunate and lunotriquetral injury, should also be mentioned because, I repeat, is frequently overlooked. Many factors have been associated with increased risk of displacement, including increased age, dorsal comminution, and degree of dorsal angulation. A very interesting study, McKinney, found that early instability was 10 times more common in patients older than 80, 6 times more common in fracture with any form of dorsal comminution, and 5 times more common in fractures maintaining 5 to 10 degree of dorsal angulation if compared with any degree of volar angulation. These data may be some kind of predictable of instability of the fracture, and to have in mind that multiple try of close reduction is unnecessary. Non-union of the distal radius is uncommon. In one study with 2,000 distal radius fractures, Beckern found a non-union rate of 0.2%. They said that the risk is open fracture, severe comminution infection, tissue interposition, devascularization of the bone ends, and pathology, lesion predisposed to non-union as osteoporosis. We think that on our part that over-distraction by applying external fixator may be the reason of the non-union. Of course, in patients who don't collaborate with the treatment protocol as remove the cast or something like that is also risky non-union, but non-union is really rare complication. Extensor pollicis longus rupture is a known complication after distal radius fracture, and is believed to occur more frequently after minimally displaced or non-displaced distal radius fracture. Exactly incident in non-operative treatment patient is not known in the literature, and the question is why it's happened in minimally or non-displaced distal radius fracture. They believe that it is increased pressure within the non-ruptured tendon sheath jeopardize the blood flow in the already poorly vascularized part of the tendon, leading to degeneration and rupture. Of course, hematoma inside the sheath interfering with the production of synovial fluid and deprive the tendon and the tendon nutrition. Song found incidence in his work, rupture of the external pollicis longum tendon, of less than 1% following fracture of the distal radius. In this population, most tendon rupture occur between 4 and 8 weeks after trauma and affecting people over age 50 years. There is a very interesting study by Saito and colleagues from this year where the dimension and morphology of the Lister tubercle were measured. The relationship of the fracture line to the Lister tubercle was also looked, as we see on the picture. This study identified the risk factor for tendon rupture as follows. The fracture line is located distally of the Lister tubercle, and the morphology of the Lister tubercle is characterized by the shallow peak height and a higher radial peak than the ulnar peak. Interesting paper from this year. The incidence of the external pollicis longus rupture after volar plating is between 0 and 1% and usually occurs about 3 months after fixation. Half of these cases is because of prominent dorsal screw, but it is not the only reason. In other half, we believe that maybe the reason is the same as in non-operatively treated patient. We strongly believe that we agree that the index finger extensor transposition is the best option of all of these cases. Flexor tendon rupture is a serious postoperative complication due to attrition between the plate and the tendon. One multicentric retrospective study included 28 patients with flexor tendon rupture following volar plate surgery. All cases with rupture included Sung grade 1 or 2 plate prominence. The average time to tendon rupture was about 2 years. It is a rare complication after non-operative management, and we find a few papers and only as a case report. We present the case of a 57-year-old female patient had a poorly fused fracture of the distal radius, but 20 years ago, and treated non-operatively and functioning very well. One morning, he wake up with inability to bend his index finger and a slight swelling. On a magnetic imaging, state a break in the continuity of the fiber of the profundus of index finger, held only on the fibrous cord and part of the tendon sheath, and intraoperatively we find damaged fiber of the superficial tendon also. Volar on the radius, a deformity is visible, of course, but the edge was smooth, and the damage of the tendon, as we see on this picture, is volary toward the retinaculum, not toward the radius. Our thinking, does the edge of the flexor retinaculum, due to the pressed tendon by the callus, cause the rupture, and not just the sharp edge of the carpus, especially if we think about the time of 20 years has passed. Regional pace syndrome is a common and highly disabling postoperative complication characterized by persistent pain, swelling, change in the skin color and temperature, which severely affect patients' quality of life and functional recovery, and always have some complication at the end of this treatment. The exact etiology of the complex regional pace syndrome remains understood, but many research indicate that its occurrence may involve multiple mechanisms, including abnormal response in the peripheral central nervous system, neuroinflammation, sympathetic dysfunction, and change in neuroplasticity. One of the theories emphasizes how local damage from trauma or surgery or both activates the peripheral nerve system, leading to the release of inflammatory mediators, and which aggravated the sensitivity of the pain receptor. The rate of incidence of complex regional pace syndrome after fracture of the distal radius has been very vary in the literature, from 1 to 37%, and often rise with increasing severity of the fracture. Older age and female gender significantly increase the risk. In one paper, said the patient with complex fracture and those undergoing internal fixation had a higher incidence, particularly in the late postoperative period. In the other paper, said osteoporotic patient faced increased risk in the middle to late postoperative stages. Maybe, just maybe, excessive distraction with an external fixator can raise the risk of complex regional pain syndrome development. For fracture, treated non-operatively, maybe increased pressure under the cast can be provoked in factor. However, the true cause remains unclear. Trigger finger has been reported in 2 to 6.5% of cases after distal radial fracture, although the exact origin has not been defined. The exact cause of triggering after distal radius isn't fully understood. The injury or the surgery may disrupt the normal tendon pulley structure leading to the triggering, but its look as also as Dupuytren disease. In one paper, 11% of patients with a Colles fracture developed Dupuytren nodule between 3 and 6 months post-injury. They find that this disease and contracture were usually mild, without significant progression during 2 years. It is not clear if the trauma is a direct cause, but in Dupuytren and the trigger is mostly like that predisposition awakened by the trauma. And malunion is the most common complication of non-surgical treatment of fractures of the distal radius. It may be intra-articular, extra-articular, with symptoms, without symptoms, but we should not forget that corrective osteotomy is a very challenging problem with a completely unpredictable clinical outcome. And we strongly believe that prevention of loss of the reduction is the best course of action. As with many conditions of the hand and wrist and in orthopedic or medicine generally, the appearance of the radiography does not correlate with patient symptoms. Many older patients are low demand, especially we have in our population, and do not want operation. But malunion and its solution, corrective osteotomy, is such a broad problem that I think this can be a separate topic and suggestion for our future webinar. Thank you very much, and greetings from Belgrade.
Okay, thank you very much, to Professors Tomislav and Zlatjana for your talks. And I think that the goals of this conjoined meeting has reached. We presented a general aspect of distal radius fractures with the treatment options, anatomy, advancement on diagnosis and treatment, even in complex distal radius fractures, as well as complications. I am sure that these lectures have put food for thought on your minds and could be a subject of great debate. However, since the difference of time between Belgrade and Mexico, we're going to skip the discussion part of this session. And we must remember, as Dr. Pavlik told us, that the Serbian Hand Surgery Society has 15 members, but they are of very high quality. And we are very grateful to collaborate with you, and we hope to repeat this soon. Thank you very much and have a great night. Bueno, por último, nada más para dar los avisos con respecto a la sociedad. Si alguien tuviera algún comentario o pregunta para el doctor Diego Valencia, que dio una excelente plática, este sería el momento de hacerla. Y si no hay ninguna plática, entonces em, podemos pasar a perdón, ninguna pregunta, podríamos pasar a, a los avisos para terminar la sesión. Entonces, aviso número 1, ya realizamos el pago correspondiente a nuestra inscripción a la Federación Internacional de Sociedades de Cirugía de la Mano. Y le solicitamos y le recordamos que esta y otras gastos que tiene la sociedad, pues se solventa a las inscripciones de todos nuestros socios. Entonces, pues ya va a empezar un nuevo año, así que si pueden hacer sus pagos en diciembre del año 2026 o en enero, serían muy bien recibidos. Les mandamos el costo y los datos de pago por el chat de WhatsApp. ¿Qué ventajas tiene ser socio? Muchos se lo preguntan, ya los hemos repetido en otras sesiones. Obviamente hay precio especial en el Congreso. Eh, las constancias del Consejo Mexicano de Ortopedia y Traumatología, nosotros damos la constancia que son miembros y eso les da puntos para la recertificación. Y lo que sí les quiero decir es que este año les está pidiendo el consejo a nuestros socios que les pongamos la antigüedad. Entonces es necesario que estén al corriente de los pagos para que nosotros podamos expedir la constancia con la antigüedad. Esto hay que mandar un correo a la dirección de la tesorería para que estén actualizados en la base de datos y estemos seguros de que son miembros titulares al corriente al momento de expedirles sus constancias. Em, bueno, la convivencia de la sociedad ya va a ser en unas 3 semanas. La están organizando la doctora Telles, la doctora Natalia y la doctora Carla. Y también les vamos a avisar el día y el lugar. Esperemos que todos puedan asistir. La idea es estar un par de horas platicando y presentarles un poco más de las actividades del siguiente año, incluyendo el Congreso. Y con respecto al Congreso, nos da mucho gusto decirles que ya tenemos confirmados a la doctora Diane Riley de New Hampshire, quien va a venir a hablar sobre el uso de ultrasonido e incluso nos va a ayudar en un taller. Y los doctores Sanjeev Kakar de la Clínica Mayo, Gregory Bain de Brisbane y el doctor Ezequiel Seidenberg de Australia. Y la doctora Tamara Rosenthal ha expresado su deseo de asistir también. Entonces, evidentemente, tenemos pues un profesorado de alta calidad, incluyendo pues a nuestros socios eh, que tienen un gran nivel académico y que van a estar debatiendo con nuestros invitados internacionales. Para todo ello pueden acercarse a cualquiera de los miembros de la mesa directiva y si tienen algún interés en colaborar, ya sea en la parte de promoción del Congreso, en la logística, en la organización, pueden contactarnos y con mucho gusto los subimos al barco. Bueno, pues que quiero mandar saludo a todos los participantes que están en línea, muchas gracias por acudir a esta sesión conjunta con la Sociedad de Serbia. Quisimos hacer algo útil para los ortopedistas que en su práctica diaria manejan fracturas de radio distal, que sabemos que es lo más común, y verlo desde otros puntos de vista. Pues muchas gracias, que pasen muy buenas noches.